Bismillahirrahmanirrahim. We'll speak about asthma in this video. While dealing with a patient with asthma, we should take history. History in asthma include asking about wheezes, breathlessness, chest tightness, cough, and during examination, we should check if the patient well or unwell, tired, able to talk in complete sentences, respiratory rate. We should measure also pulse rate. Should check the use of accessory muscles, and if there is intercostal recession, we should also auscultate for wheezes. Then we should classify the severity of the condition, if the patient is mild attack or severe attack. If the patient is in mild attack, his color will be pink, he will be alert, pulse rate is normal, respiratory rate was in normal levels, around 15. He can speak in sentences. If the condition is severe, we can find cyanosis, we can check the conscious level, which may be confused or drowsy. The pulse rate may increase more than 100. Respiratory rate may increase also above 25 or above 35. The patient cannot speak in sentences. The peak flow rate or peak expiratory flow rate will be below 50% of best of predicted. As we know that asthma is very common condition characterized by episodic breathlessness and wheezes. Other symptoms such as cough also occur. The patient often describes their chest as feeling tight. It has a prevalence of at least 5%. The symptoms of asthma tend to be variable, intermittent, worse at night, and provoked by triggers including exercise. And we consider diagnosis of asthma in any patient with episodic or variable wheezes, shortness of breath, chest tightness, or cough. The patient also may have attack or recurrent attacks of wheezing. We should ask about the troublesome nighttime cough. We should ask also about wheezes and cough after exercise. And we should ask about patient's colds, go to the chest, and we should check improvement of symptoms of asthma after treatment by asthma treatment. We should exclude also conditions in differential diagnosis of asthma, which include upper airway obstruction, inhaled foreign body, COPD, chronic obstructive pulmonary disease, diffuse parenchymal lung disease, pulmonary edema. When taking history, what's the precipitated attack, respiratory tract infection, exercise, allergen, aspirin, non-steroidal anti-inflammatory drugs or cold air. What are the symptoms? Such as wheezes, which are usually diffuse, polyphonic, bilateral, and preferably, particularly respiratory. We should ask about the cough and breathlessness. Any unusual features present, such as severe chest pains, hemoptysis. What has been the response to therapy, including inhalers, nebulizers, corticosteroids? Do they monitor their peak expiratory flow rate. When assessing the patients with severe asthma, a calm and reassuring approach can be very therapeutic. Past medical history in asthma, we should ask about any previous admissions for asthma. Has the patient even been artificially ventilated for asthmatic attack? Is the patient's sleep disturbed by asthma? What is the patient's usual exercise tolerance? Has the patient taken any days off work or school due to asthma? Does the patient have any other features of atopy, including eczema or rhinitis? Any diurnal variations in symptoms, such as early morning deterioration, which is common? Are there any associated disease, bronchopulmonary aspergillosis, Churg-Strauss syndrome, family and social history? Assess impact of the disease on the patient's life. Is there a family history of asthma or atopy? What is the patient's occupation? Any deterioration of asthma at the work or relief at work end, at weekend? There are specific occupational cause of asthma. Drugs. What is the usual treatment? Inhalers, nebulizers, corticosteroids, inhaled or oral or aminophylline? Do drugs show any precipitation of asthma, such as beta blockers, aspirin? Does the patient smoke? Does the patient have any allergies to antibiotics, animals, pets, or house dust mites? Examination of the patient of asthma should check if the patient is unwell and possibility to give oxygen by mask. If the patient is cyanosed, is the patient distressed, frightened, able or unable to talk in complete or to talk a complete sentence, tired or exhausted? If they're wheezing, distinguished from an respiratory stridor. Note better, note better that in asthma, severe asthma, the chest may be silent with little ventilation. Any sputum? If so, what is the color? Is it in plugs? What is the patient's respiratory rate? Check the patient's pulse rate. Check the patient's peak expiratory flow. In the well patient, examine her or his inhaler technique. Is there use of accessory muscles, intercostal recession? Consider pneumonia or pneumothorax as a cause of deterioration. Is the pulsus paradoxus? Is there pulsus paradoxus, which may be absent in severe attack? Pulsus paradoxus is exaggerated, is an exaggeration decrease in blood pressure on expiration, and can occur in severe asthma but may absent in severe attack, and they can also occur in pericardial tamponade, hypovolemic shock, right ventricular failure, and pulmonary embolism. We should check other causes of breathlessness and wheezes, which include pulmonary edema, chronic obstructive pulmonary disease, stridor, anaphylaxis. Patients who are at risk of developing fatal asthma include previous near fatal asthma, as for example, previous ventilation or respiratory acidosis, previous admission for asthma, especially in the last year, requiring three or more class of asthma medication, heavy use of beta 2 agonists, repeated attendances at accident and emergency room for asthma care, particularly if combined with adverse behavioral or psychosocial features. Note better in an acute attack, measure peak expiratory flow, pulse oximetry, and perform arterial blood gases to determine the PaO2 and PaCO2 and saturation of oxygen. If the saturation of oxygen below 92% and PaO2 below 8 kPa and a normal PCO2 means 4.6 to 6 kPa or elevated PCO2 are signs of life or a life-threatening attack. We will check quickly the signs of severe asthmatic attack again. The signs of severe asthmatic attack include cyanosis, tachypnea, which means respiratory rate above 25, but beware if the tiring respiratory rate may fall. If the patient is tired, the respiratory rate may fall down. Tachycardia means pulse rate above 120. The conscious level include disturbed conscious level include drowsiness, drowsy or confused condition. The patient is unable to speak. The chest is silent. Failure to improve with nebulizing beta 2 agonists. Bradycardia, feeble respiratory effort, exhaustion, coma, hypotension.